And welcome back to Inside Healthcare. As you can see, we've stepped into a mock surgery room here, and I'm joined now by Dr. Stefano Sinacropi, orthopedic surgeon. Thank you for joining us.
Good morning.
And you're going to be talking about a breakthrough new surgery using artificial disc to repair cervical spine damage to the disc.
Mm-hmm.
Why don't you tell us what you've got here?
Well,
First, a little bit about yourself.
Sure. So I've been in practice now in the Twin Cities for about 4 years. I'm with a group called Midwest Spine Institute. It's a specialty group focusing on spinal disease and injury from the cervical spine all the way down to the lumbar spine. And we have 3 spine surgeons. We have injection specialists, which are either rehabilitation specialists or anesthesiologists, and we have a team of physician assistants that can help evaluate patients, triage them, and then make recommendations as to how to treat them going forward.
So what you're going to show us today is perhaps an alternative to fusion?
That is correct. Anterior cervical decompression and fusion is really one of the gold standard operations for treating either neck pain from cervical disc disease, for treating arm symptoms for patients that have compression on their nerves from a disc herniation, or even treating patients that have a condition called myelopathy, which is when there's compression on the spinal cord causing them to develop weakness of the arms or legs, difficulty walking, things of that nature. And so traditionally, the anterior cervical decompression and fusion allows us to address all of those problems in a very satisfactory way with high patient satisfactions, really good return to work ability. It's really been a kind of a tried and true and tested procedure which everything is compared against. Over this course of the last several years in the United States, replacing the disc with movable parts has allowed us to perform all of the same functions that a fusion would do. In other words, address compression on nerves, take out the disc that's hurting, in a way that allows us to preserve the normal motion of the spine. The advantage to that would be that the discs above and below the total disc replacement, as opposed to the fusion, are going to see a lot less in the way of stresses and strains over time. When you have stress and strain over time, as you can imagine, the more the disc is moving, the more it's going to be prone to injury and to subsequently need to have further treatments like another fusion or a decompression or something of that nature.
Is it common that you have more than one disc involved in this?
It is. It can be common to have multiple discs involved. In the majority of patients, there's usually 1 or 2 discs that are causing most of the symptoms. As far as where the total disc replacement is FDA approved for usage, the standard treatment would be for a single level disc replacement, either standalone or adjacent to a previous fusion. However, in Europe, this has really taken off, and many patients are getting on planes to Europe to have these procedures done. And now here, you can use it in an off-label fashion to, for example, do a fusion and a disc replacement at the same time to address different conditions, or you can do multiple level total disc replacements, although again, that would be an off-label usage. However, patients can do very, very well from that procedure.
Maybe we can get started. You can kind of show us about this. How does it work? And you're going in. It looks like you said it's through the front of the neck.
Right. So actually, maybe I can show
Sure.
them on you. So one of the same things between the anterior fusion and the total disc replacement is that we do go in through the front of the neck. And I'm a right-handed surgeon, so I'll typically go in on the right side. And it'll be a small incision, approximately 2 centimeters, sometimes 3 centimeters, depending on how much work needs to be done. And we're very, very careful and conscious of cosmetic results. So what we usually do is we'll choose a natural crease in the neck. And try to hide the incision in that level, and then at the end of the case, really close it with a plastic surgery closure to give the best cosmetic.
So in this case, we have a big open thing, but it
Right.
wouldn't be like that at all.
So you can imagine the skin covering here. So the incision, with me standing on the right-hand side, is going to be done in a transverse fashion. Once we get beneath the skin, there's a very small muscle It's called the platysma muscle in men. That's the muscle that can bleed from underneath if you cut too deep. That's a very, very thin muscle. We kind of just go through it with finger dissection, and then right underneath the area where we make the incision, you basically have the central muscles of the spine, and right beneath here is the trachea and the esophagus running right behind that. And then on the sides is your carotid artery and the carotid sheath and other vessels. And in between that is the plane where you're going to get down to the disc. Now, this is called a true trainer, and this is a model which is used to actually train surgeons to do this type of procedure. So you can see that the disc has been removed here. I'm going to just put a retractor here in place so we can go through the procedure.
And how long does a procedure like this take?
This type of procedure typically will take approximately 1 hour to do the procedure. What we'll do is, once we have the disc exposed, we'll mark the midline because you really want to make sure that this disc is centered in all views, and I'll kind of go through a leveling device that we have. And so that's the disc actually taken out. Once the disc is taken out, the next step is going to be to take what we call the offending pathology out. So any of the disc that's actually pushing on the nerve roots, we're going to clean all that disc out and actually be looking right at the covering of the spinal cord, which is called the dura. Once we've done that, we actually clean out the spaces for the nerves, so you're actually looking at the nerves on the spinal cord at this point. Once that's done, then kind of the carpentry begins to put in the total disc replacement. So the first thing I'll use is this leveling device. And so this device will go into that area here, and that will allow me to shave down any bone so that the disc is not tipping back and forth. So here it's already been leveled, so this is nice and level. Then we'll choose a size. So in this patient, we'll just say that they're a 6 millimeter by 14 millimeter size. This is a very standard size that we would use. So we put a sizer in, and we're doing this all with the fluoroscopic imaging, and so we're watching this all on the screen. Once we're very satisfied with our size, we're going to choose our implant. Now, just going through the implant, there's several different implants available on the market. This is an implant called the Prestige Disc Replacement System. This is a Medtronic implant. This is the first FDA-approved total disc replacement system here. And basically, this is a stainless steel on stainless steel joint. And so you can see it's kind of a ball and socket, but it actually allows sliding front to back and tipping back and forth. So this really does a nice job of replicating the normal motion of the cervical disc, and we'll see that later on a video of that. And so this.
Go ahead. I was going to say, who would be a candidate for this versus, say, fusion?
I think that's a great question. Many of the patients that are candidates for fusion are a candidate for the total disc. One thing that absolutely is a requirement, at least in my practice, and again, people sometimes go differently from the guidelines, but you want to show that there's motion. So we'll get x-rays of the patients flexing back and forth, and if those x-rays, we can actually measure motion of the disc, then those are patients that I would consider a candidate for a total cervical disc replacement. If there's no motion, there may be some arthritic changes in the back or something that's not allowing motion. So it's difficult to restore motion in that situation.
So when you have fusion, can you move the head as much or not at all?
I think that's a great question. For single level fusion, actually the mobility can be quite good. You will lose mobility at the level that you've actually fused.